All right. Good morning, everyone. For those who I don't know, my name is James Badu, and I'm one of the residents here in the Department of Neurosurgery, and I'll be giving grand rounds today. So I wanted to start my talk with a quote by the famous author Maya Angelou. And the quote says, "If you don't know where you've come from, you don't know where you're going." And in a similar way, the guys that I used to play pickup ball with back home in DC, they would say it slightly differently, but they would say, "Don't forget your roots, James." And the reason for that is, well, no matter what arena you're talking about, whether it's technology, medicine, law, you see people, you see giants in these fields, and you see them for what they are today, but you don't understand the journey. And what that does is it robs you of an appreciation and a respect that is deserved because of the process to get to where they are today. So, example of this, it's easy to see the iPhone 13 and the cool cameras, the screen, the pixels, all the different apps that you can do, the touch screen or whatever it may be, and see Steve Jobs for who he is, and take it for face value and how he changed the way that we interact with technology daily. But you can't see and appreciate that without understanding where he came from. Here he is with Wozniak actually working together on the beginnings of the first Apple computer. And so you can see how the infancy of these technologies, kind of coupled with the work of Alexander Graham Bell with the creation of the phone, gave us the iPhone that we have today. And I would venture to say, at least within our department, about 85% of people have. And here you can see all his various iterations. So you can't appreciate this without understanding where he came from and the journey he had. In the same way, it's easy to look at Elon Musk, obviously an icon in the technological world, and see him for SpaceX, for Tesla, and seeing how this guy is a visionary and literally trying to put people in space and kind of challenging the whole automotive industry and creating an electric car that has lasted. And it's easy to take him for who he is, the billionaire that he is today, and forget that this was how he started. And his beginnings actually start back with PayPal, which he ultimately sold to eBay and got him a nice chunk of change to allow him to start a lot of his ventures that he went on to do. And that group, actually, they've been coined the PayPal Mafia. That group of people actually went on to do a lot of different things in different facets of the world today, whether some of them went on to different venture capitalisms, others went on to develop a lot of the companies that we know today, whether it's Yelp, obviously Tesla and SpaceX, LinkedIn, something we all use regularly, as well as YouTube. So these guys like Jobs and Musk all have certain characteristics that are kind of common between all of them. They're countercultural, they're extremely dynamic, they're aggressive, they're innovators, they are extremely hard-headed, they're resilient, and they're disagreeable. They don't have to have everyone liking them because they know that sometimes is what's taken to kind of push the boundaries forward. So then what does this have to do with neurosurgical spine or this talk and organized neurosurgery? Is I would actually venture to say that for both of these facets, neurospine and organized neurosurgery, it's extremely easy to take it at face value and not understand where it came from. So for example, spine. It's easy to see spine and see it for all the technologies that it has today, whether it's, the various types of instrumentation, retractor systems, inner bodies, expandable cages, pedicle screws, robots, augmented reality, virtual reality. It's easy to take that and ride that wave, but not understand where it came from. In the same way, all these organizations that we all know, the AANS, CNS, the Society of Neurological Surgeons, ESMIS, ISAS, NAS, it's easy to take these and at face value and just see them as how I've been guilty of seeing them as, conferences that we're able to attend, great times to be able to, present our research, build our CVs, another line on our resume. And obviously, when you're at these conferences, being able to meet and see all of your colleagues from around the nation and have a good time in unique cities. So I can't speak for everyone on the talk, but I can say personally, I took those two things for granted. I was very ignorant to the process of how spine became what it is today, or organized neurosurgery, and extremely naive to it. So the core of this talk, the title of my talk, is The Footprints of Giants, the Pioneering Journey of Spinal Neurosurgery. And the goal of it, we'll discuss these various things. We'll talk about the growth and the beginnings of organized neurosurgery at large. We'll talk about operative advancements in spine. We'll also talk about the rise of neurosurgical spine within neurosurgery. We'll touch base on organized neurosurgical spine, some of the battles of orthopedics versus neurosurgery, talk about spine in the media, as well as what it looks like presently. And all along the way, I'll put in little snippets of how our department was pivotal both historically and present day in the propelling of spine forward. And the heart of it is so that I hope that we, obviously understand where we came from. So that, I would love, in particular, to touch base with, or reach out to the residents, the fellows, the mid-levels, and the students with this talk. But I would really, really love the faculty who've lived this era to chime in at any time. Obviously, I'm speaking into something that I didn't live out, but you guys understand more of the nuances of all these different stages. So with that said, let's kind of get underway. So the journey of spine starts back in the 1800s with Dr. Alban Smith, actually. He was a general surgeon, and he actually saw a patient with a cervical spinal cord injury after having had a fall 2 years prior from off a horse. On his exam, the spinous process was eccentric to the right, and so he decided, hey, this patient should go to the OR. And he took the patient to the OR, and intraoperatively, he saw bone fragments pushing on the spinal cord. And so what he did was he removed the lamina with a saw. And I don't know if he knew it, but what it ultimately was that he did the first successful laminectomy in 1,500 years, something that we take for granted as bread and butter for stuff that we do daily and multiple times a day. He had done the first one. And the patient actually did really well. They had an improvement in sensation in the hands and the thighs afterwards. And he went on to publish his paper in this journal, the North American Medical and Surgical Journal, back in 1829. So fast forward just a little bit, and Sir Dr. Horsley, actually used this same laminectomy technique to perform the first successful intradural extramedullary tumor resection. A couple of years later, obviously the neurosurgery father, Dr. Harvey Cushing, attempted to remove an intradural intramedullary tumor utilizing the laminectomy technique that Horsley and Alban Smith had done, but he actually stopped after he did his myelotomy and kind of closed up. And actually, to his surprise, the patient improved. And this is actually how the method of extrusion that we know today came to be, that how we can use, and we sometimes use this for the management of some spinal cord tumors. And then in the 1900s, early 1900s, not much progress was made in spine. And partially because the mortality of dealing with spine patients was extremely high, 25%. And honestly, most of the pathology that was dealt with was related to two things. One, it was trauma. And then second, it was POTS-related deformities. And POTS being, obviously, as we know, TB of the spine. So then in 1911, orthopedic surgeon Dr. Albee actually developed a technique for bone graft in the spine of patients with POTS-related deformities. He actually would use portions of the tibia, which he would plug into the spine to help with fusion. And he published the paper, as you can see it here. And then after he did this, he said, oh, well, the harvesting was a big process. And so he went on to create a bone mill, which is ubiquitous in all aspects of bony-related surgeries. And this was a massive decrease in OR time and an improvement in patient safety. Oh, I don't know. There we go. So in contrast to neurosurgery at the time, the general surgeons were actually very well organized. And they had they had a meeting of the American College of Surgeons in 1919 in New York City. And this was actually where Dr. Harvey Cushing presented his experience with brain tumors. He gave his talk, and at the end of the talk, Dr. William J. Mayo, who was the president of the American College of Surgeons and would ultimately, along with his brother, go on to create the Mayo Clinic, he went on to say, "Gentlemen, we have this day witnessed the birth of a new specialty, neurological surgery." And with this, Harvey Cushing then kind of was spurred on to trying to recruit people who were similar to him. So at the time in the country, there were a few players that were really doing dedicated neurosurgery. Dr. Cushing, of course, Dr. Charles Frazier in Philadelphia, who would go on to create the Frazier suctions that we all use day to day, and Dr. Ernest Sachs in St. Louis. So Cushing then drafts a letter to Sachs at the time, and here's the letter, where it was written in December of that same year. And he said, I would like to include in a society, and that's what Cushing's heart was, to create a society of neurosurgeons. He said, I would like to include those who do little less than neurosurgery. He said, but I'm conscious of the fact that the general surgeons who are interested in primary neurosurgical techniques do not talk our language, but it may be necessary to have included him. And he said he wanted to limit the membership. And he proposed a few people down below, including Mixter and Horsack, which were his fellows, obviously Sachs and Frazier. And then in Baltimore, a gentleman we all know as Dr. Walter Dandy. So this was the birth of the Society of Neurological Surgeons, or the SNS. And you'll come to find out later on why we call it the Senior Society. The first meeting was in Boston in March. The first officers were Harvey Cushing, obviously, and Ernest Sachs. And the format of it was semi-annual, twice a year. In the morning, the host surgeon would basically have an operative clinic in the morning, kind of going over techniques or what have you. And in the evening, they would have afternoon sessions, which they kind of present scientific papers or research, and they max the membership at 45. So fast forward to present day, our department is fortunate to have some of our attendings in this senior society, including obviously Dr. Harros, Morkos, Levy, Wang, and Dr. Komitar. And from a resident and fellow perspective, it is this society that ran and runs the intern boot camp or the run course that we all know about and have participated in. So 1920, the SNS is created. Fast forward 10 years, and what advancements are being made in spine? So at this time, Walter Dandy in Baltimore actually unintentionally performed the first discectomy in 1929. He actually thought he was removing a tumor and was surprised to find out it was just cartilaginous tissue. And then in 32, Mixter and Barr, Cushing's fellows, did the first intentional discectomy for sciatica. And here's Dandy's paper, where it's actually pretty impressive, the drawings of the time and how correct they are. But he described it here to the left. The lesion is a completely detached fragment of cartilage from an intravertebral disc, and it's surrounded by serum. And it's undoubtedly of traumatic origin. And here is the paper by Mixter and Barr, which was actually published in the New England Journal, titled "The Rupture of the Intravertebral Disc and Involvement of the Spinal Canal." And once again, it's pretty impressive, the drawings and the anatomic photography that they have for that time. And it was published in such a high impact journal like the New England Journal. So in this time, the number of dedicated neurosurgeons was continuing to rise, but because the SNS was so elite and exclusive, a lot of people missed out from the opportunity to participate in neurosurgical forums. And so a group of people got together, and here they are: Dr. Van Wagenen, we know of the Van Wagenen Fellowship, Dr. Sperling, Dr. Seams, and Dr. Temple Fay. They all got together and they exchanged letters about building this new society. And it was here in these letters that they actually referred to the SNS as the older or the senior society. And that's how we call it and how we know it as today. But with this organization, they actually feared the backlash from the senior society if they were to go forward with it. So basically, Temple Fay writes in one of his letters saying, the heart of our new society should be the advancement of neurosurgery, research, techniques, patient care, early diagnosis, management of postoperative care, all to decrease mortality at large for these patients. So then in October of 31, they actually met in DC, and they decided, okay, we're going to do this thing. And they made a list of invitees. They said it was going to be multidisciplinary and this and that amongst the neuro side of things. And the most important decision they made was they decided to consult Cushing on it. And so then that week, Van Wagenen goes on to meet the person who they call the chief, or Dr. Cushing himself, to tell him about the society. And he says here in his letter after he came back, he said, all told, he was very much in favor of the idea as presented to him. He said that he had felt for a number of years that the old society had become too gastronomically inclined to be of much use. And I believe that he will also allow us to use his name in connection with the society. So a very Marcosian way of saying that he felt the senior society wasn't doing as much as it should be doing, and said, hey, I give you my blessing to move forward with this. And this was where the Cushing Society came from. So because of Cushing's backings, the invitees that were invited, they all accepted. And Cushing offered Boston once again as the home for the first meeting, and it was held in 1932. And here Cushing gave a talk and he cautioned the members saying, remember that in 10 years' time, another group would be coming along that would look upon the present one as senile and antiquated. Kind of a word of caution and kind of telling them to be careful as they move forward and to not fall into the same trap that the SNS had fallen into at that time. So now we have both the SNS and we have the Cushing Society on stage. But unfortunately, history repeats itself. The Cushing Society kind of fell into the same trap, and it became very inaccessible for other people trying to get involved in organized neurosurgery. And so there were a few other attempts that were made to break this mold. And here are two of them. One is the Academy of Neurological Surgeons, which was created in 1938. And this is what we know as today as the Academy, and the Neurosurgical Society of America of 1942. So then as time is progressing, there's still, obviously neurosurgery is growing. And even amongst the small subspecialty, there were people even then who were having a leaning interest towards spine. And one person is Dr. Ralph Clower. And when I say Clower, I'm sure that, we all think of the Clower retractors that we all utilize regularly, but that's only one part of who he is and what he did and contributed. He actually did the foundational work, initial work for what would eventually come to be the posterior lumbar interbody fusion, the Pliff, as well as the ACDF, or what was initially called the Clower technique. So he actually went and was giving a talk at the Cushing Society in 1946, where he was presenting his 10 years of experience doing these lumbar interbody fusions, where he would actually harvest some of the iliac crest graft and plug it, create these bone plugs that he would plug into the disc base after doing a discectomy and removing the cartilaginous end plates. And then in an interview for the AANS, he kind of recounts what it was like presenting this data. And I hope this comes through. And please tell me if you guys can't hear it.
And do heavy work.
But here it is. It's about 40 seconds.
And have no further trouble. I read a paper at the Harvey Cushing Society meeting in 1946 on my first 100 cases. And my success rate was 94%. And I had followed these I had followed these cases for 10 years. And I had a good follow-up from them. And I thought I had a good operation, and my patients loved it. And I did because I didn't have a lot of feedback, see. Well, my paper was accepted by my brethren at the Harvey Cushing Society with stone silence.
Disbelief?
Absolute. Not only disbelief, but disagreement. I got no applause. I got no comment.
What do you think was the main issue of contention?
Well, the main issue of contention was expressed by my friend Jimmy Watts, who came from Virginia, and with his broad Southern accent, he got up and said, and I quote, "We are neurosurgeons, and as such, we should confine our activities to the trephine and the rongeur and leave the hammer and the chisel to the orthopedic surgeon." And he got a standing ovation.
So you can see, even within the realm of neurosurgery at the time, the people who were interested in spine had a big speed bump that they kind of had to overcome, even amongst the community. So this is actually the beginnings. The paper, Clower kind of undeterred went on and published this paper, which describes the Pliff technique. And here, once again, you can see the drawings of the time. And as I said, he was also pivotal in the design or the surgical development of the surgical technique for what would become the ACDF. But at the time, there were no, Midas Rex drills. There were no PEEK or titanium cages, no plates, no screws. And what he actually would use was a Hudson cranial drill, get on the disc space, drill towards the symptomatic side. So if someone had a right-sided radiculopathy or weakness, they would drill towards the right side, take out the disc, the bone, and then put in a bone plug. And ultimately, this is how fusion would take place. So then fast forward, at the time, it's post-World War II. And the big thing that was being dealt with from a spine perspective was post-poliotic scoliotic deformities. And in particular, there was a hospital, the Southwest Respiratory Foundation, where a lot of these patients were taken care of and where Dr. Paul Harrington, the orthopedic surgeon, worked. And a lot of these deformities at the time were managed with non-operative measures, so a lot of conservative therapy. And in particular, I think one of the techniques was called the Schroff technique. And they would be a bunch of physical therapy maneuvers to help, straighten out the spine. And that's what's demonstrated here in this figure with the kid. But this wasn't the case for all patients. Some were, as we know, non-responsive to it. So Dr. Harrington said, something needs to be done for these kids. And he went on to say, well, why can't we just prevent the spine from continually deforming? And so what he did was created what we know today as the Harrington Rod. And he would actually manufacture these rods in his garage the day before surgery, and then go on to implant them. And obviously we know them when we see them in scans now and what it is today. And it did, in fact, help to a point with these patients. And that hospital that he worked with ultimately, was the beginnings of what we know today as the March of the Dimes. So then in the same era, in 51, the number of dedicated neurosurgeons continued to grow. And this kind of pushed forward the birth of the Congress of Neurological Surgeons, or the CNS. And this was the first organization in neurosurgery that was inclusive. It allowed everyone that wanted to join in neurosurgery that could join. There was no limit to the number of members. And the goal of the CNS was to develop the junior neurosurgeon or the fellow or the resident, and to help them in their development. So now we have four big players that have or five, I guess, big players that have come to be in the first 30 years that this journey started. And of these, the two that really surfaced to the top were the Cushing Society, which was really dedicated in the advancement through research of neurosurgery, and the CNS, like I said, which is really like an educational platform for a lot of the young neurosurgeons. And they ended up being the two biggest voices in neurosurgery at large. So fast forward to 1966, Dr. Frank Mayfield, who was the president of the Cushing Society at that time. When I say Dr. Mayfield, we all know him or know the Mayfield clamp, and that's probably the first thing that comes to mind. But that's only part of his contribution. Actually, he was also pivotal in working alongside this gentleman here, Mr. Keys, I'll call him, who was actually his medical illustrator and the original Swazo, who worked on the designs of the first spring-loaded clips and clip appliers for aneurysm surgery. And he then felt that there was no unified voice for neurosurgery at the whole. He had 4 or 5 different societies that were out, everyone kind of doing their own thing. And he said, in order for us to kind of have progress together, we need to have one unified voice. So in what is now called the Mayfield Proclamation, he declared the Cushing Society as the official voice of neurosurgery at large. And not only did he do that, he said, rather than calling it the Cushing Society, let's rebrand essentially, and let's change the name to the American Association of Neurological Surgeons. And this is what we know today as the AANS. So now you can kind of see that the Cushing Society is synonymous, if you ever hear about it, with the AANS. So fast forward to 1978. At the time, Dr. Drake in Canada, obviously world-renowned vascular neurosurgeon, was the president of the AANS. And Dr. Al Roten down at the University of Florida was the president of the CNS. And at this time, in the realm of spine, the orthopedic surgeons dominated it. There was actually about 8-to-1 ratio, 8 orthopedic surgeons to 1 neurosurgeon doing dedicated spine. And during, in this letter that he wrote as president of the CNS, Dr. Roten described kind of his feelings about this while he was president of the AANS prior. And here's a snippet of the letter. He said, as president of the AANS, I experienced a gnawing discomfort that intracranial surgery overshadowed spinal neurosurgery, even though spine surgery represented more than half of the workload of neurosurgeons. As president of the CNS, I drafted a letter to the president of the AANS, Dr. Drake, outlining this concern. And I proposed the development of a spine section. The goals outlined in the letter were to give more dignity to spine surgery, instill a new sense of the importance of spine surgery within our specialty, to stimulate subspecialization in spine surgery, strengthen spine research and educational programs, because Dr. Roten felt that spine surgery had been taken for granted. So what him and what they then created between the AANS and the CNS together, they came together to create the joint section. And that's how we know the spine section as today. And that's why it's called that way, because it was a collaborative effort between both the AANS, the former Cushing Society, and the CNS. So then spine, organized spine is kind of coming together. There was a young guy in South Florida making waves in the spine realm, someone that we all know and love, Dr. Barth Green. And back in 1985, he was actually selected to be the chair of the first joint section meeting. I don't know if Dr. Green's on here. If you'd like to chime in at any time about what that was like, please feel free to, sir. And they had the first meeting down in Greenleaf, Florida, for the spine section. Fast forward to present day, and here are the last 12 spine section presidents, including our own Dr. Michael Wang, who led in 2019. And it's interesting because even the omnipresent Dr. Jacques Morcos had his hands in the spine realm and an interest in spine as the AANS board liaison a couple years prior for the spine section. So as we know, in 2019, the spine section was here in Miami. It was led by Dr. Wang and obviously as well with Dr. Uribe and Dom Korek, and it was a huge success. And so now the spine section has been created. So onto the stage comes spinal instrumentation. And this was like a big game changer and a source of a lot of contention moving forward, and you'll see why. So up until this time, neurosurgical spine was still getting organized. Surgical techniques that we were doing were decompressions, a lot of tumor resections and discectomies. And this was actually in contrast to the orthopedic surgeons, which were very well organized to an extent, and they were doing a lot of thoracolumbar instrumentation. And they actually vehemently or adamantly opposed instrumentation by the neurosurgeons. And so this kind of shows the stepwise progression of a lot of the thoracolumbar instrumentation that the orthopedic surgeons were doing. We talked briefly about the Harrington Rod down there in the 1950s, and it also progressed from there. You know, there was some anterior instrumentation techniques. One of the big ones that was pivotal was the Loke, what would be called the Luke or Loke technique, where it was the first time that they were contouring rods to adjust for thoracic kyphosis and lumbar lordosis, and there were bilateral sublaminar wires to reinforce that construct at the time because screws weren't a thing. And then even down here in Miami, Dr. Schuffelberger was pivotal in the creation of what was called the Miami Moss system, which used laminar hooks and rods together to help with derotation surgery. So you can see the point of this was that the orthopedic surgeons really tried to lay a lot of hold in the thoracolumbar world in particular. So there was supposed to be a slide, I don't know what happened to it earlier on. So when Roten and Drake got together and he commissioned the development of the spine section, he really charged 3 people. There was Dr. Ed Connolly at the Ochsner Clinic in New Orleans, one of the surgeons, Dr. Ed Stewart, I think, at the Mayfield Clinic in Cincinnati, and Dr. Sanford Larson at the Medical College of Wisconsin. To kind of help organize this spine section. And that's what gave way to the spine meeting in Clearfield. So Dr. Larson at the time still kept moving forward. He actually is credited for the development of what we know today as the lateral extracavitary approach for the thoracic and lumbar spine. And here's the paper talking about that technique. And he developed the first complex neurosurgical spine fellowship in the country. And he and his fellows utilized some of the early thoracolumbar instrumentation techniques that I had talked about earlier. So then in '87, now we're getting to like, as the residents, a lot of our lifetimes, the AANS comes together and they say, all right, we need to create a spine task force. And the reason for this is because they felt, and rightfully so, that neurosurgeons should be trained to instrument on the entirety of the spine, not just what was being done at the time, which we'll talk about that in a little bit. So in '87, that same year, at the CNS meeting in Baltimore, Dr. Volker Sonntag, obviously from the BNI, actually ran the first practical spine course. And it was actually interesting because he recounts what it was like leading this course, because the quote highlight of the course was learning how to twist 2 strands of 24 gauge wire 3 times per centimeter into a configuration that was easier to handle than the 18 gauge wire that they were doing a lot of the posterior cervical fusions with. Because at the time, this was really, from my understanding, what a lot of the neurosurgeons were doing. They were doing a lot of wiring, whether it was the Harms, the Gailey's, the Brooks technique, and mostly in the cervical spine. And ortho, once again, dominated the thoracolumbar realm. So as you can see, there's kind of this boxing match between orthopedics and between neurosurgery over this territory of the spine and instrumentation in particular. And one of the podcasts that Dr. Wang did is an interview between Dr. Luis Toomey-Allen at the BNI and Volker Sonntag, where he's talking with Dr. Sonntag about this very aspect, and in particular about a book that he had written called Backbone. And so in the event that Sonntag's talking about here took place in about '88. And I hope once again that this plays through. It's about a minute and some change, but it's actually very interesting and paints a pretty good picture. So here it goes.
Backbone, and I wanted to expound on that. There's a scene with an orthopedic surgeon that was operating alongside you because, as you said, these cases were collaborative. It was management of the cervical fracture, and in the book you just referred to him as Dr. S. Yes. So I assume that to protect the guilt. So your surgical strategy for that case was to use lateral mass plates, a technique very much in its infancy. Lateral mass fixation now, because of largely your efforts and efforts of others, that it's commonplace. But in 1988, Dr. S was completely taken aback.
Yes.
Can you describe that exchange?
Yes. An orthopedic colleague, the patient had long bone fractures, but also C6-7 bilateral facet, which we couldn't reduce with closed reduction. So I decided to take no surgery to reduce them and also to fixate them. And my orthopedic colleague says if he could sculpt with me to take the bone. And that was common those days. Orthopedic colleagues would take the bone and we would do the fusion of the neck. And I said, sure. And I mean, we also can take our own bone in those days, but I said, sure, it wasn't the case. And so as we were ready to, after we reduced the bilateral facet, we were ready to put in the lateral mass plates. And I used a drill to put the hole in for the screw. And Dr. S, who was taking the bone from the hip, looked up and he says, what are you doing? And he says, I'm going to put this blade in with these screws. And he says, we've been wiring this for years. And that's why his head snapped up, because wiring obviously doesn't cause a pulling sound. And he said, and I showed him the blades, the screws, and the anatomical landmarks that we're using. And he says, I'm out of here. Take me off the output move. I want nothing to do with this. And he walked out.
Did you ever go with him again?
No.
All right, well, let's fast forward to from 1988 to 2021.
So that kind of gives you an idea of what the relationship at the time, or the dynamics of the relationship, were like as the neurosurgeon kept pushing forward into the realm of spine. And I talked with Dr. Levy about this briefly in his time at the BNI, and he was saying how when he was a fellow there, it was one of the few places in the country that was doing that kind of instrumentation. So you can kind of see that the boxing match ensues between ortho and neuro, but there were some attempts at collaboration on a national stage, in particular the CSRS, the Cervical Spine Research Society, as well as NAS. They were kind of developed and created for all spine comers. And as you can see, even NAS today, if you're a physical therapist and you're interested in spine, you can come, kind of a thing. But on the granular level, on the academic stage, there was still a pretty contentious battle between the two. So now you see these are the players in stage, and you can see it's kind of funneling in terms of how organized spine has come together. But in the 90s, there was a massive forging of bonds and between orthopedics and neurosurgery, and it really revolved around two things. It was the pedicle screws and the FDA. So I didn't know anything about this. I was completely naive about it. And as I was preparing this talk, you really gain insight into it. But in the 90s, in particular, 94 to 99, there were apparently multiple class action lawsuits between against not only the surgeons and the societies of neurosurgery and orthopedic surgery, but manufacturers as well. The FDA told manufacturers that they needed to stop the production and promotion of what they called bone screws in the pedicles, or what we know as pedicle screws, because of the limited amount of information regarding their efficacy. And they demanded valid scientific evidence before they would reclassify these instrumentation. So what this does is instantly, the surgeons, the spine surgeons, or anyone using spine implants, as well as industry at large, were criminalized. And this became a massive media outpour. Here's just one article out of the Washington Post titled "Pedicle Screws Are at the Center of Controversy." Here in the article, they say that about at the time, 350,000 Americans had been instrumented without any proof that it was safe or that it worked, and against the express warning of the FDA. So you can see here how now the realm of spine has been kind of stigmatized, and to an extent, to this day, they're still trying to break those molds. So, now backs against the wall, both orthopedic and neurosurgery, now their common territory is threatened. And what do is what I've called the historic collaborative rebuttal. So the heavy hitters that be in the organized realms of NAS, AANS, CNS, as well as the orthopedic and SRS all get together, including Dr. Dickman at the BNI and Dr. Garfin at UCSD. They got together and they said, okay, we need to put together this study to prove this. And here's the paper that was published in Spine in '94, which was a cohort study of pedicle screws and fixation in the thoracic, lumbar, and sacral spine. And what they showed in the study was that the use of the bone screws in the pedicle, or the pedicle screws, improved the fusion rates from 70 to 90%. And in their conclusion, they kind of made a jab at the FDA, and they said, the results of this study represent, quote, valid scientific evidence, and go on to say how they feel that because of this, it demanded a reclassification of pedicle screws to be available like other spinal implants, because now it's shown efficacy. And that's, from what I can say, has happened. And so in a historic first, neuro and ortho backs against the wall because their territory was threatened, come together and in a unique way. And this kind of blossomed into, a collaborative innovation. So while all of this stuff is happening, we're still figuring out the academics and the anatomics, of the spine. And in particular, two gentlemen, Dr. Camden, who we know from the Camden Triangle, as well as Dr. Wiltsey, who we know from the Wiltsey approach and the Wiltsey fusion system. They kind of come up with a lot of their novel work. And using this as a backbone, a lot of others innovated from it. Dr. Foley, then went on to create some of the tubular retractor systems for MIS discectomies, and then Dr. Fessler in Chicago with the development of PERC lumbar screws. And here shows how some of that collaboration starts to take place. And as this moves forward, this was the development and the beginnings of minimally invasive spine surgery. Fast forward to 2007, it was the creation of ESMIS, which is a society dedicated just to this. So here are a lot of the players that be and there's many more, ISAS and the SRS and all that stuff, but with the time constraints, this is the ones that I've kind of delved into for the talk today. And fast forward to the present day, and in particular, our department. Obviously, I told you, like, from, Dr. Green and the joint section in the beginning to, how we are now, our department is, one of the largest departments, one of the highest volume centers, one of the busiest spine services, and has one of the largest spine fellowships. And it's easy to take that at face value and just ride that wave. But once again, what it does is, if you don't understand the roots of it all, and understand where we've come from, you really get stripped of that appreciation and that respect for the journey to see how our department came and its involvement, both past, present, and in the future, in the realm of organized neurosurgery and spine at large. And a lot of the players that helped forge and pioneer this in the realm of neurosurgery spine had those same characteristics. They were countercultural, they're aggressive, they were innovators, they were disagreeable, resilient, and extremely dynamic, to allow us to reap the benefits, if you will, of seeing how spine is today. So, with that, I feel that we kind of touched on all the things that I hope to talk about in this talk, and also our department's impact. And with that said, I'm happy to take any questions, or more so hear from any of the faculty that want to chime in.
I think that was an awesome job, James. I actually really learned a lot, especially from the beginning stuff. And I congratulate you summarizing it succinctly, and my colleagues for really being movers and shakers in this spine world.
Yeah, James, I would echo Dr. Levy's comments. I mean, you wrapped this up very nicely. I learned a lot as well. I mean, the history is so important. You can't plan for the future without knowing the history. So thank you for educating all of us on this. It's fantastic.
Of course, thank you guys. All righty. If there's nothing else, I think that's it.
No, hey, James.
Yes, sir.
Again, fantastic. No, I'm going to use this opportunity to ask maybe Mike or Alan, what do you think spine surgery will look like in 30 years from today if this history is continued? What can I ask you to foretell the future for us?
Yeah, Jacques, that's a great point.
Yes.
And the concern always is that spine's going to break off as a different specialty. And we see that like in China, where spine is becoming so uniquely distinct from other elements of neuro and orthopedics that they'll have their own residency and all this. Obviously, you and I don't support that kind of a thing, but this is one of those things that I see Dr. Wynn on now that has been discussed again and again and again. I hope that doesn't happen, but because at the root, we're neurosurgeons, right? But it is definitely been discussed, and it's definitely something that has some legs. So I think for the young people, they may or may not see something like that in the future. There's actually an American Board of Spine Surgery that's being debated right now. It's been around for about 10 years. Very controversial, but that conversation would be offline for sure.
My 2 cents, not so much about how we're organized, but how we will practice, is that I think there are two major elements that will continue to move forward. And one is, minimally invasive, and that will become more refined, with endoscopy, et cetera. But I think the other thing, and Mike has mentioned this numerous times in numerous publications, is that there will be a huge push in moving spine surgery from inpatient to outpatient. I think it's really important that we're not behind the 8 ball in that, because in academics, we're very focused on hospital-based care, and that's going to change because of finances and the way healthcare is moving. And I think my colleagues are having a meeting this week to sort of extend this conversation about how we get into the ACS, which stands for ambulatory care surgery, in a more formalized way at a university center. It's much more difficult to do it in a university setting than it is in private practice. But if you look at private practice spine surgery, you'll be hard pressed to find a practitioner who doesn't have a significant element of his practice in an ACS.
Let me just add first of all, it's a pleasure and honor to be part of this department, but that was a phenomenal presentation. Let me just reflect a little on personal history, because I was there as a resident, junior faculty member and chair and so forth. I think there are two individuals, or at least one organization, one individual. Turned out that the military in World War II pushed and mandated that cervical injuries were the domain of neurosurgeons. It's unclear to me how that came about. But second, when I was in the service in '76, George Hayes was the Surgeon General and neurosurgeon, and he mandated that all spine was the domain of neurosurgery, not orthopedic surgery. And so many of the people coming out of what was then the obligatory volunteers, in other words, the Berry Plan, came out with enlarged experience in the spine. The second person was Dave Kelly from Wake Forest. He was on the board and the RRC in the early 80s, mid 80s. And he saw what Thor Sundt did in regard to carotid endarterectomy. Thor Sundt made the RRC include some numbers for carotid endarterectomy. And the vascular surgeons, without question, were the dominant force in carotid endarterectomy. By mandating it, it forced organized neurosurgery to include numbers of carotid endarterectomy. Dave Kelly did the same thing in spine and started the whole emphasis in the RRC that training programs had to include numbers of instrumentation. So that, in essence, was a way that helped in the spine wars. Another factor is, I think the practice community geographically similar, at least I found that when I went from Virginia to Seattle. But interestingly, I don't think the academic institutions around the country were similar. So in Virginia, neurosurgeons with Crutchfield and a Crutchfield clamp and so forth, we really had a major control of spine. At the University of Washington, the orthopedic surgeons owned it. And because of Dave Kelly's mandate and so forth, the programs throughout the United States, including the University of Washington, we had to gear up. So I would add to the magnificent presentation to look into the potential influence of George Hayes in the military and also Dave Kelly's enforcement through the RRC and also the boards when you came up for your board examination, there would be questions very targeted on the spine. So again, great presentation. I really enjoyed it.
I appreciate it, Dr. Nguyen. Thank you very much.
Yeah, thank you, Dick. Welcome again.